Hi, I'm Ralph Preston, and today we've got a special guest, and for this special meeting, Ask a Neurologist, and that's my friend and colleague, Dr. Mark McDonald. Dr. McDonald is a neurologist, and he's also the CEO of his own company, Centrillo, and he's got a wife and kids, and he's a very, very busy man. He's also a very knowledgeable man, and so today's going to give us a little uh, brief bit on his background and what Centrillo can do for stroke survivors. I think it's kind of interesting and much needed. And then we'll do the Q&A thing. So, Dr. McDonald, thank you for taking time to do this. We all appreciate it. And why don't you go ahead anytime you'd like.
Sounds great, Ralph. Thanks. Always a pleasure, and good to see everybody. Like I mentioned just a little while ago, I've seen a few of you now. I think a few times, so always nice to see a familiar face. I've had kind of an interesting journey to get to this point. So my background actually was so 12 years ago, I started doing work in stroke technology, and my mentor was one of the neurologist who helped come up with the clot busting medicine for stroke. He also was one of the first people to, well, he was the first neurologist to bring the stroke ambulance. I don't know if you've heard of this, but there is a ambulance with a CT scanner that they created in Germany, and he brought that over from Germany to the U.S. And so I've been interested in stroke technology for the last 12 years. I've been doing telestroke for almost a decade now, seeing patients remotely, often on the hospital side, where patients come in with a couple hours of symptoms and we make decisions about treatment. I actually did my fellowship in neuroimmunology, which seems unrelated, but one of the interesting opportunities there was uh, when you have a stroke, not all the time, but often, you have a neurologist who might see you once, and then you're off to your primary care doctor. And in neuroimmunology or in the multiple sclerosis world, we have a multidisciplinary team who sees patients. We were seeing patients with occupational therapists and physical therapists together with the neurologist so they could collaborate. We often had help from a dietitian, and we were seeing patients every couple months, and that was our patient. They knew who their doctor was. They could pick up the phone and call, and that was their doctor 3 months out from being diagnosed, 6 months out, 2 years out. And I think that we have an outdated notion of what care should be for stroke, that oftentimes it's seen as a one-time event, and you have your stroke and here's what you need to do for the next few weeks, and go back to your primary care doctor and they'll do everything for you. And I think that the way stroke behaves is more like a chronic disease, more like MS, from the standpoint that not only are there uh, not only is there a risk of another event, or there's risk of related events, but we have changes in the way that we think or the way that we move, and even emotional changes that are actually physiological changes from the stroke, not just a change in your life circumstances. And so I've I've tried to combine my two backgrounds, in neuroimmunology and stroke, and bring a service for stroke that is multidisciplinary. So rehab specialist, dietitians, but also meant to provide that continuity. So uh, not be a one-time thing, be the team that works with you for 6 months, 12 months, 2 years, however long that we feel like patients benefit from us. So that's what we've developed. We've been working with Ralph and Stroke Buddies for a while now. We've really evolved what we do, and so the way that I would describe where we are in our current stage is we are a telehealth clinic. We have neurologists. We have three neurologists right now, and we've got a couple occupational therapists, and we do work with dietitians. And what we're doing primarily is we work with hospitals who don't have good follow-up care for stroke patients. Most hospitals don't, but the ones we're working with have really bad follow-up care. And so we pick patients up when they leave the hospital, and we send devices to the home. We teach the patient or caregiver how to download the app. and then we do all the other stuff that I described. We do the telehealth sort of multidisciplinary. So I'll see the patients, or my colleagues will see the patients, and then we'll collaborate with the rehab specialist. We'll have a dietitian, and what we try to do with technology is technology is not a solution or a reward in itself. I think that the reason why technology is important is it gives us better data so that we can keep track of blood pressure, that we can understand physical activity, that it is hard to. I mean, I don't know if you remember what you had for breakfast yesterday morning. I don't. I think it's sometimes hard to remember our medicines. It's sometimes hard to keep track of our physical activity, or at least know if this week is better than last week. I think it's hard to keep track of things like blood pressure and our labs up to date. And the problem is, 30 years ago, that the primary care doctor could do a lot of those things, but really they can't anymore in the current healthcare system with the access problems we have. And a lot of times they don't have the expertise to do it well. So that's what we're trying to address. That's where we are, really a tech-enabled telehealth service. But we think of ourselves as a neurology practice, just like a brick and mortar practice, just with a little bit of a twist. So so happy to answer. I mean, in the era of ChatGPT and Gemini, I'll do my best with questions and and or at least contextualizing stuff that you can find probably by yourself. So happy to answer questions, both from the lens of a neurologist who's primarily does stroke, but also neuroimmunology and an immunology background. So.
So here's your chance.
Okay. It's been 3 years since my stroke. Can y'all hear me?
Yeah, I can hear you, Brian. Yep.
I can move my arm, I can walk, but this nerve pain is killing me. They got me taking gabapentin 900 milligrams 4 times a day, and it helps, but is there anything I can do about this nerve pain?
Yeah, there's a lot that you can do, but it is a lot of trial and error. And there's alpha lipoic acid. There's a supplement that some of the doctors that deal with neuropathy and painful neuropathy really like, and there's good data for that. Um, there is there's some interventions like devices, something called a dorsal column stimulator, and there's other devices that essentially distract. It sounds kind of strange, but it's distracting you at a very base level, or a level before it gets to your kind of conscious awareness. It's distracting you from the pain. And so there are a few things that do that. There's capsaicin cream. There's some creams you can do that have some good data. Um, I find that I they don't have the best reputation, but what I try to do for our patients that we work with, especially if they have post-stroke um, pain, or that sort of central pain from stroke, we try to get them in with a pain clinic that we really like, that we trust, that isn't just going to do crazy off the wall stuff. But sometimes you do need to think outside the box, and you need somebody that's not going to just put you on a medicine with lots of side effects and just let things go. And so
Right.
I, what I try to do in general for my whole practice. I mean, my practice philosophy is I'll take care of you until we can get you in with the specialist. And so I do that if someone stroke patient has epilepsy, I'll manage their seizures until we get them in with a trained epileptologist. For pain, I think that there's so much out there now that's not just medicines with side effects, that it's probably worth getting in with them because they can do a ton. And the other thing is, pain after stroke is complicated. Is there an element of spasticity? Is it all that sort of central neuropathic pain? Um, and I think that it becomes a little bit more complex. I think if you're just on gabapentin, I mean, and that dosage, you can certainly go up on that dosage. But I often find it's better to have a a, a multi-pronged approach and not just push a medicine. I think that's probably true of everything in what we do for our patients is, medicine's helpful, but it's not a silver bullet. And I think that for 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 pain 3 years out, it's we're gonna have to use some tricks to kind of get a handle on that.
You know,
We
it's
did, yeah,
it started like a year out, and I kept thinking, it was my nerves waking up. Maybe it would get better, but
yeah.
it just doesn't get better.
The other thing too is you have to make sure that we're not missing anything. Is there a pinched nerve in the same distribution or something else? So, and sometimes it's not a matter of it's something entirely new, but maybe there's something that's causing it to get worse. I mean, you, that timeline isn't far off the mark of what you can see with pain after stroke, but you also want to make sure there's not anything else going on that makes it worse. So, um, I think pain is one of those things where you could do a pretty thorough evaluation and try a lot of different things. And if you have Medicare, if you have insurance, there's probably a way that's going to be relatively cheap to kind of get you in with a
It did.
specialist and monitor that. But there's things to try beyond gabapentin now until you get in with a specialist.
Yeah, I'm working on a pain team
Well,
and a neurologist. But thank you.
well,
Yeah.
I got to say, I've been through neuropathy for like the last past 16 years. And I thought that it was just a thing with the stroke. I've been through the same thing with the tingling sensation. But I had my stroke just 16 years ago, and I had neuropathy after this stroke.
You had neuropathy after the stroke.
Yes.
Can I
Yeah.
just? Sorry, I didn't want to interrupt. Then I was just going to ask if I've got a neurology question, neuropathy question to follow on from that. If it's when you're ready.
Yeah. Yeah.
I wanted to. Is it fine to talk? I just wondered, is there any kind of? I think correlation is the wrong word, but any kind of direct connection between stroke and trigeminal neuralgia, which I seem to have suffered from since I've had 2 cerebellar strokes, and I think I'm thinking in lines of the potential connection with the cerebellar nerve and the trigeminal nerve, or the cerebellar artery and the cerebellar nerve, which I think connects somewhere around in the debuncles. Is it? It's called the debuncles at the back there.
The peduncles.
Anyhow,
Yeah.
I wonder if there's a known kind of connection. I'm in the UK and I get sort of a vague response from anybody related to stroke medics when I ask.
Yeah. So trigeminal neuralgia is kind of its own entity. And the syndrome of trigeminal neuralgia, it's usually this really, really severe, sharp pain that occurs, and we don't really understand exactly why people get it. I mean, sometimes it's thought to be like a post-infectious inflammatory process. Sometimes there's a vessel, called like a vascular loop or part of a vessel that's pressing on it. I think you can get numbness and pain in a trigeminal distribution from stroke, but the characteristics of the pain and the quality should be a little bit different. So it's probably going to be more of a dull, burning pain that's always there, rather than this really sharp spiking pain that will go away and almost go away completely, but it's excruciating when it's there. So the brainstem stroke, or the strokes that affect your cerebellum, the fibers that communicate information back and forth to the face, that's the trigeminal pathway, is there. So if you had a stroke that affected your cerebellum, presumably you had a stroke that affected sensation in that trigeminal distribution. But my guess is that if it's from the stroke, it'd probably feel a little bit different than what patients experience with trigeminal neuralgia, which is really that classic, just sharp, excruciating, but very brief, almost like electric zaps pain. Whereas post-stroke pain, not always, but it can be a little bit more constant, a little bit more of a dull, burning pain.
Right. Okay, that's great. Thank you.
And Keith, did you have a question about I know you shared with us you've had pain for almost 16 years. Did you have a question you wanted to ask about that?
yeah, the question was, does it ever stop? Or does it keep going? Because I had to paint for 16 years. And it's like, does it ever end?
Yeah, that's a good question.
Really, does it ever end?
I have not seen a so I as long as I've been practicing, which is about a decade now, I haven't really seen patients have complete resolution of symptoms by some pain by itself. There's something about
Oh,
pain that I think
oh,
is post-stroke pain. I think is a little bit closer to. I don't know if you've heard of this, but there's a thing you can get after a stroke or a neurological injury called phantom limb syndrome, uh, where you
okay.
can well you get it after you've had a traumatic accident, but you can sometimes get similar situations with stroke or any kind of brain injury, but you'll get these sort of phantom pains in an appendage that isn't there or an arm that isn't there. And
Yeah, I get that too.
yeah, and the thought is that something happens where the brain learns the wrong way or wires the wrong way, and then you're kind of stuck.
Yeah.
You're kind of stuck with that wiring the wrong way. So I think pain is more like that than it is because the thing is with stroke, pain doesn't happen right away. So or usually does not. So there's an exception to that, but for the most part, pain doesn't happen right away. And so where I think of timeline of improvement with stroke symptoms, it's what are the deficits that happen right after a stroke? What's the injury that happens? And then eventually the brain will improve or you see a lot of improvement for the first couple months up until 9 to 12 months, and then the rate of improvement slows and becomes a little bit more of a plateau. But I think pain is different. Pain sometimes will actually start weeks to months afterwards. Actually, that 10 the timeline that Brian mentioned was something that we see quite a bit. That sort of 7 to 10 months, you start to see seizure, you start to see pain, and I think there's a that indi suggests that there's some problem with the wiring or something happens where it's the recovery process that leads to some problem with the processing, and that I don't think is going to have the same trajectory of improvement that you normally expect with walking or speaking after stroke. So,
Okay.
so I've seen it last for years. I mean, I haven't seen a lot of patients that will get pain from stroke and then it goes away in a year or two. I think it's closer to a problem with the wiring or the rewiring of that section.
Okay. I say I always feel I hang on. I always feel that it felt like snakes crawling up and down my leg.
Yeah, so that that is and is it the just one side?
And both of my legs.
Both
It's
of you? Okay.
it felt like a bunch of snakes or a bunch of chipmunks, a bunch of rats and stuff crawling up and down my leg.
Okay, okay. So that
And
that
then I go and take a look and there's nothing there.
yeah, that could be something different, Keith. Anytime you start to get symptoms on both sides, that worries me about something
Uh,
other than stroke and that sensation
oh,
of
Lord.
bugs or animals moving that can be
Yeah.
from a true neuropathy or from medication side effect actually can give you that. So, but yeah, anytime it's on both sides, you
Okay.
worry a little bit about something other than stroke. We say neuropathic pain just to refer to anything from the brain to the nerves in your body, but anytime it's on both sides, you wonder if that's maybe something other than stroke related.
And Keith,
Okay. Well,
Keith,
all of
what wasn't your stroke 3 years ago?
my show was 16 and a half years ago.
Okay, my bad.
I'm just a living warrior.
Okay, sorry, go ahead. I was gonna say,
What was that? Oh, I missed that. When it what's this whole phantom? You said it was the phantom thing. Um, Phantoms would, well, I forget the term used,
Yeah,
but it was the phantom thing.
the phantom sensation. Yeah, phantom. Sometimes they say, you can have phantom limb, but you can have phantom sensations. It's that feeling of something that isn't there. Yeah, there's other things that can cause it, but anytime you have something like that, it does suggest more of a wiring problem and not a normal recovery situation.
Oh,
So
Lord.
yeah,
Okay. So
yeah,
I got something else wrong with me probably then.
yeah. If it's in both legs, I mean, without getting more information, Keith, I'd be worried about something else. And I think
Okay.
William or uh, Mr. Claremont, did you have a question?
Yeah, totally forgot it.
Okay, no worries, no worries.
I have
My
a
mind is gone.
question.
Okay.
go ahead.
Hi guys. Hi. My name is Tiffany. My mother, so she has suffered from 4 hemorrhagic strokes. And I think one of my biggest questions, so I plan to go into the medical field. I finished undergrad. I do actually want to go into neurology or
Okay.
neurosurgery. I love neuro. And I actually worked with Westchester on like I worked with them in their stroke unit
Mhm.
and I was able to so I learned so much about strokes. And I think one of my biggest questions or I think issues that I kind of have is I don't feel like hemorrhagic strokes are taught enough or they
Mhm.
study enough about them in the medical field. Do you think at any point that's going to change, or do you guys work? Because I know they say it's so rare, or it's like 12% have, hemorrhagic strokes. But I know with my mom, because she's in a stroke group, the majority of them has all, like, they've all had hemorrhagic strokes. And I
Mhm.
do feel that, for example, with my mom, they missed it at the hospital. They left her waiting for 8 hours, sent her home. They said she just had a headache. They missed where the bleeds were. They had the next day a neurosurgeon ended up catching it, and they did say, well, it's extremely rare. So I don't know if they're not being taught, I guess, to where or what to look for
Yeah,
or the
yeah, that's a
signs
good
to look
question.
for.
So I think hemorrhagic stroke. So if you the type of hemorrhagic stroke I think you're talking about, or the one that you would potentially miss, um, you can have a small subarachnoid or small subdural.
She had 2 subarachnoid,
Yeah, so
cerebral.
subarachnoid can be missed. That's usually the one that's missed if you're going to miss one. So just for everybody, and some of you here who've had hemorrhagic strokes probably know, but there's really 3 types. There's subarachnoid, there's subdural, and then there's intraparenchymal, uh, and all those kind of fall into the intracranial category. But intraparenchymal, you usually see that it's big and bright on the CT scan. It's in the tissue. Subdurals can sometimes be missed, and subarachnoids can often be missed. And the challenge with the subarachnoid, I think that in theory, uh, so the problem is what you teach in med school doesn't always translate. And so good example is med school, they always say worst headache of your life,
Yeah, that's how she
and
described it too.
yeah, and the problem is, there's a lot of people that come in kind of worst headache of their life, and I think it takes a lot more experience to understand when someone's saying that they have 10 out of 10 pain and when someone's really in 10 out of 10 pain. And I think the other challenge is when you come into the hospital and they don't see it bleed on CT. And sometimes the neurosurgeons in hindsight can say, "Oh, well, yeah, it was there," but it can be subtle, or it may not even be there on the scan. I think the challenge is right now, what you're supposed to do is get a lumbar puncture. And I don't
Oh,
know if anyone here has had a lumbar puncture, but those
no.
are really painful. They're horrible to do. The ER doctors are on a busy shift and they do one a year and they don't want to necessarily do it because they're not good at it and it takes forever. And if it, and to be fair, that the blood is often seen on the CT. So you have probably a 5 or 10% chance of missing it on the CT scan. So from their perspective, it's, oh, you had this bad headache. We didn't see it on the CT scan. What are the odds that someone is going to actually have a subarachnoid? And what you're supposed to do is have a trained professional see the patient, put all that information together, and then say, well, you know what, it's high enough chance that we need to go ahead and do the lumbar puncture. And I think that's the challenge is you in order to miss in order to not miss one of those, you're probably going to need to do 10 lumbar punctures on somebody that didn't need it.
So
And
what does the lumbar puncture show? That's really interesting.
it shows blood in the CSF.
Oh, and cerebrospinal fluid. Oh, so that's
Yeah.
okay. I didn't know
So
that.
that's what you're supposed to do for
Wow,
subarachnoid because
that's cool.
people know they know that it is
Oh,
sometimes missed.
that's
So
not.
so the meds, the medical students all get the vignette of worst headache of your life, headache
Yeah,
CT is negative. What do you do? The answer is lumbar
right,
puncture. I think what happens is once you get out in practice and you start to understand the limitations of the hospital,
right.
and then
Okay.
it's how confident am I this is subarachnoid, and how much better are the scans now than they used to be. The scans still miss it, but scans still miss it. And
Right.
I mean, I had a patient the other day where we did the lumbar puncture and it was positive, and so
Wow.
I do think that
Wow.
it's very tough because I mean that's the trade-off. I think there's a part of medicine that is it's tough because we practice on a population level. So good
Yeah.
example is TPA or TNK. Now it's tenecteplase, but it's the clot busting medicine.
That's what I was gonna ask is do you think there'll ever be something like that for hemorrhagic? Let's say like something that will maybe, obviously stop the blood or stop the bleeding or
yeah. I mean, I think that they're pretty close to getting things that stop the bleeding.
Mhm.
I think the problem is subarachnoid. It just it it's so quick. It can be so quick,
That's
and
not-
how much it worsens
Yeah.
that it's really even if you have a good treatment. I mean, so there's good neurosurgical treatment, but even if you had a good uh medicine for it, it's the issue still. My guess is where you're going to see the most progress with that stuff is early detection, early screening, kind of pre-event, because once you've had it, other than just getting to the hospital real quickly and identifying it really quickly, there's just not much you can do.
Yeah. So
In terms of dramatic improvements in what's currently there already, in terms of standard of care and all that. So, but yeah, I mean, the first step is to not miss it. But the issue is it. Sometimes we do things that are good for most of our patients and bad for patients. A good example is TPA, TNK. The odds are 4 to 6% chance of hemorrhagic stroke. But you
yeah.
can't tell someone who gets TPA and has a massive hemorrhagic stroke that, well, it's still good that this happened because you're only in the 4%. Most of my other patients benefit. I mean, the challenge is we practice this sort of population level, and sometimes that's not good for the individual patient. And so I think the subarachnoid, if we were to try to never miss a subarachnoid hemorrhage, we'd have a lot of people getting stuck by the ER doctors and probably having, injuries I mean, you get bleeding, you can get a hypotensive headache because there's a CSF leak. And I mean, there's all kinds of terrible things that happen. And so,
Wow.
it's just, it's still, medicine is still evolving, but there's always a trade-off. But unfortunately, I think that your mom was probably on the other end of that trade-off and they missed it, something they should have caught.
I heard a real loud whooshing noise in this ear while the stroke was happening. Is that common? It was
Uh,
loud.
yeah, I've heard that happen. I don't know. I mean, so I think that my best guess is that whenever you have a stroke in the brain, your blood flow kind of gets rerouted. And there's a few vessels that are close to there, and so sometimes you can get a clot in the veins or increased pressure in the veins, and that can cause whooshing in your sound. But if you have a stroke, then presumably you can get a change in your pressure, intracranial pressure, and that could cause it. But this is probably one of those moments where ChatGPT or Gemini might give you a better answer than me. But that'd be kind of my initial guess based on the physiology. But we see that sometimes. I mean, there's certain strokes that can cause deafness in one ear, like anterior cerebral artery. But the whooshing sound, usually that's a blood flow change.
With my stroke, um, I saw like kaleidoscope colors, and that's why they said I had that it was just a migraine, but I was screaming in pain, and they let me sit for 8 hours and then sent me home.
Oh gosh.
But later I found a neurosurgeon and another neurologist that I love better, and they all saw the four right away, and they asked me if the doctor saw it from the ER, but he said he saw the two bleeds, but he told somebody that was with him that not to worry about that because they would dry up.
What?
Is that like
Yeah, I suspect that there probably was a miscommunication down the road. Or somewhere that happened. I think there probably was a miscommunication because um, it would be pretty unusual to send someone home with any kind of bleed. That
That's
unless,
why, yeah.
yeah,
Like,
yeah.
it was an awful.
and then
Um,
they
And by the
kind of
time when she went back, and because the neurosurgeon called her back and he was like, no, there is a bleed. Why'd you send her home? So she did go back. I mean, the doctor did get in trouble, but because he should have never sent her home. And then
yeah,
he did another MRI. That's when he found four bleeds.
yeah.
That's
I
when
mean,
he
I
said,
think I think I think there's two things that are true. One, you should never send someone home with a bleed.
no.
Two, that you don't always do surgery on a bleed because it can they you can reabsorb the blood or it can dry up as you said. So I suspect what happened is they missed a bleed and then maybe they
I,
hard to say, but they
I
definitely shouldn't have sent you home. So
No, and then
yeah,
I found out later that it my neurosurgeon now and my neurologist feel it was also connected to
COVID. That's a huge
COVID.
question too that I had was because she had COVID 7 times and they
yeah,
don't know why, but each time obviously got worse, 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 and worse. By the time she had COVID for the sixth time, that's when all the blood vessels just burst.
yeah. So there
So at
was
the same time. So we
you
really don't know the
you were
connection.
60% more likely to have a so
Mm.
in any given day, maybe you have a 0.3% chance of having a stroke or something like that. If you're high risk, and then after a year, maybe that adds up to you have a 5% or 10% chance. Then 10 years, it's higher. But with COVID, those 3 days after you were positive, you were 60 times more likely to have a stroke
So
in
there
that
is a
3 days.
correlation to it. Oh wow. I
Yeah.
never knew that. There is.
Um,
Okay. That makes sense.
the problem is the data around COVID is all observational or
Right.
longitudinal. I mean, we didn't have a ton of randomized control trials, but we know a few
Mhm.
things. So we know that your risk of stroke was likely much higher. That was ischemic, I think, but much of ischemic strokes are driven by changes in blood pressure. So
Yeah.
presumably that could also have caused a spike in blood pressure in a subarachnoid. We also know that where the virus actually binds is the there's a receptor that's related to blood pressure and why different ethnicities and races have differences in essential hypertension or side effects from essential hypertension. It binds there. And so I personally saw with Delta a lot more bad outcomes in certain ethnic groups in people in their 40s and 50s, like neurological outcomes. There's some data for why that could be, but we didn't really validate that just because there wasn't a ton of good research at the time. So COVID is certainly a risk factor, and the problem with COVID is that all the strains are different. So I don't know if that was true for Omicron or if I don't know if it's true now. But it was different. I mean, it did create an increased risk. You did see some bleeding in the different types of bleeding that were known to be related to COVID, but there wasn't necessarily subarachnoid. But I do think that you can kind of put two and two together and say, well, if it increases increases your blood pressure and increases your overall likelihood of having an event, then why not the subarachnoid?
We already had an overall likelihood of having the event because of our family history. We do have a family history of strokes, but they were in their 60s. She was in her 50s, but then again, like you said, with COVID, I think it just kind of exacerbated that.
I saw someone mention about the COVID vaccine. Again, we're without
I'm
kind of getting into
She's allergic. That's why she can never get vaccinated. We tried
really?
and wound up in the hospital.
Yeah. So that's the thing about vaccines. They're not benign. It's a risk benefit thing, right? It's back to this sort of, do you do a lumbar puncture on 10 people to catch the one bleed or do you not? I think vaccines made sense for Delta because I saw a lot of people die with Delta. I don't know that it made sense with Omicron and beyond. We know that you have autoimmune reactions to vaccines. We know that some of the cardiovascular things that happen were related to the immune part of COVID, not the. So in theory, it's plausible that you could have an immune reaction and even a clotting event or a stroke after the vaccine. But I think the odds of I mean, the likelihood, the increased risk from a vaccine is probably relatively low, but in theory it can happen. And that's the thing, right? I mean, there's a difference between likelihood and
Right.
and like you could say something's a 2% chance, but it could still be the thing that caused it, right? I mean, having a bleed after TNK is 4 to 6% chance, but you can still have a bleed that's caused by the TNK. So I think with the vaccine, it's plausible that the vaccine could have led to the stroke. Does it mean that you have a high chance every time you get a COVID vaccine of having a stroke? Probably not, but it could certainly be related.
Thank you.
Can I ask
We got a couple of people who've had their hands raised for a long time. We're about a couple of people took their hands down. I think Gary was first, so go Gary. And then Melanie will get to you and anybody else.
Hi, Dr. Mark.
Oh, hey, Gary.
I was wondering, from your experience, do you know of any common stroke survivor habits that add to their stroke risk they might not be aware of? So I know you've spoke before about some aspects on nutrition, and I remember you mentioning something about combinations of medicine. So is there anything that's common that stroke survivors themselves could make efforts towards lowering their own risk, and how do your teams help further prevent stroke risk?
Yeah. I mean, I think the biggest thing is probably blood pressure. I know it's not as sexy as genetics or these other things, but we have a huge problem with how we measure and monitor blood pressure in the U.S. Your average change, so what they call your standard deviation, which means what's the amount that your blood pressure changes, and that's normal. Like if you measure blood pressure on a couple times a day a week, that average value that it changes by is actually anywhere from 10 to 12 points. And so that means if you check your blood pressure once or twice every 6 months, it could be a 150, it could be a 130, it could be a 160, it could be 110. You don't really know where you stand. What we find is a lot of our patients who have a stroke, we find out that they're much more hypertensive than we ever thought, that they have a problem with high blood pressure and didn't know it. So that's a big thing that we do. We make sure to get a blood pressure device in the home. We track it regularly. We try to get about 80 to 90 measurements a month. And what we find, two reasons why we like to do it. One, a lot of patients have high blood pressure. Two, some of our patients have low blood pressure. And if you've had a stroke and you've had trouble walking and you have falls or you have, that can really put you in a tough spot. So we'll check orthostatic hypotension. So one common cause of dizziness as you get older is your blood pressure drops when you sit or stand. So we'll look for that. I find most of my patients are not in the perfect range. So a lot of them have hypertension, a lot of them have hypotension. So what we'll initially try to tackle is the first month or two we use medicines, and then medicines have a limit. You eventually have to stop using medicines. You keep people on medicines, but you can't keep pushing medicines, because if you try to treat someone who has a really high blood pressure and you try to get their blood pressure perfect, because of that natural day-to-day change and week-to-week change, you're going to make them be hypotensive and cause a fall or cause them to pass out. So what we try to do is we use medicines to get people in a safe range, and then we use lifestyle to get them blood pressure really in the perfect range. And we track sodium intake is a big one, so low sodium diet, physical activity, and even a little bit of weight loss goes a long way. It's different for everybody, so we try to keep tabs on what sorts of factors influence blood pressure for that person. But we've had a lot of success with, just cutting out a little bit of sodium really helps this patient, or 10-pound weight loss was all the difference for this patient. I think the other thing that's big is there's a lot of miseducation, or there's a large kind of misconception about statins and cholesterol. And so the reason why statins are good, and frankly, that there's a case for most adults being on a statin, is because we don't have a great diet in the US, and we're also horrible about physical activity. And so we have what's called high systemic inflammation. And that's really what drives hypertension and drives a number of other conditions. And there's an anti-inflammatory effect of a statin. And so what we do for our patients that can't tolerate statin is we'll check their inflammation levels. I saw a patient earlier today. She wants to get off her statin. Her cholesterol is kind of in the middle of where it wanted to be, but her inflammation's off the charts. So we are not taking her off her statin, and we're trying to target her inflammation we referred her to a dietitian. We work with the dietitians that are covered by insurance. So she's seen a dietitian, and we're really honing in. She's a high sodium consumer, so we're trying to target her sodium. But I think that it's not just having a high cholesterol level, it's having a high cholesterol level plus high inflammation that creates problems. And so, if you can get your cholesterol down and your inflammatory levels down with diet or exercise, great. I'll take you off the statin right away. But I think there's too many people that say, "Oh, my cholesterol is not that bad. I don't want to go on a statin." Well, your cholesterol may not be that bad, but your inflammation levels are probably pretty high. And I think I think there are people that stop statins prematurely, and that's another big problem we see.
So, do you know of a correlation between inflammation and success in physio? Is there a measurable restriction? I doubt that there is, but obviously high inflammation, the joints are harder to use, the muscles are harder to use. Do you have any information on that?
And can you all hear me okay? I hear there's just a little bit of a almost like we're underwater, kind of an echo sound. But Gary, it's a good question. I don't know off the top of my head like the magnitude of that relationship. I mean, I would assume that. So I'm going to extrapolate a little bit. We know that secondary injury after stroke is largely driven by inflammation, and so we know that inflammation affects recovery in the brain. I don't know sort of musculoskeletal or like the muscles and the tissues how much, but inflammation is sort of intrinsically related to repair. You need some inflammation actually for repair, but too much is bad. And so they're definitely interconnected. I don't know. I can't speak to the magnitude. But we're starting to check the inflammatory levels for all of our patients because I think it's an important metric. The way that I think about, and I've become more of a measurements guy over the last 5 years, and I think the whole point of analytics and that stuff is we want to find a problem before we have to intuit a problem. Before we have to have an intuition about a problem. The point of metrics is let's find the problem while it's small before we're aware that the problem is there. And I think that's
How do
where,
you measure inflammation? Sorry for interrupting.
yeah. So we look at there's good data on the C-reactive protein. There's a few other ways, but the C-reactive protein kind of got a bad rap by primary care doctors because they said, well, most people in the U.S. are high. And so if everyone's high, what's the point of the measurement? But what people miss in that is that the changes, so the improvements in that, so when it gets worse or when it gets better, that is highly correlated with reduced cardiovascular risk. And so the fact that it's high, I mean, people still use it quite frequently for stroke prediction algorithms, for management related to high cholesterol. I think it's a really valuable marker for tracking improvement. So the absolute levels maybe are more or less, or they're helpful sometimes, but not always. But I think the change in it, there's really good data that the change in it is meaningful. So that's the way that I like to check it. There's some other ways you can check it, like looking at relationship between your white blood cells and platelets. There's some ratios that are pretty well studied, and there's a few other fancier labs that probably cost $5,000. I mean, they're just not feasible to check, but we use C-reactive protein.
All right.
C reactor?
It's called CRP or C-reactive protein.
CRP. Okay.
Yeah,
And is that a blood test?
it's a blood test. Yeah.
Okay.
Yeah.
All right, we got 3 people wanting to ask questions. I said Melanie was next. Nita, we'll get to you in just a sec, and then Linda. So, Melanie, go ahead.
So my question is a little different. I was diagnosed about 15 years ago of having ocular migraines.
Okay.
They didn't do like any other test and not walk in the room and ask me my symptoms, said that's what I had, and discharged me from the ER. When fast forward, this whole time I've been having these what we thought were ocular migraines. And when I had my stroke in May, it started out with what I assumed was an ocular migraine. And the doctor had told me, hey, if you ever had a stroke, because I was worried from family history, me being the youngest, unfortunately, but from family history, I knew strokes ran in the family.
Mhm.
And when asked, they said, don't worry, you're too young to have a stroke. Nothing to worry about. Ocular migraine, you will know the difference because of the headache will be the worst pain you ever feel in your life. I have a very high pain tolerance, which I try to not really tell them because they don't care. All the doctors I've talked to don't really care. When I had my stroke in May, I thought it was an ocular migraine, and I went to work, did work, finished work, went home, went to bed, got up the next day, went to the ER. They're like, yeah, it's just an ocular migraine. Went home, went to bed. Next day, followed up with my PCP, who was like, this shouldn't be going on this long. Let's send you
Yeah.
to a different ER. And then that's where they found the stroke. My question is, all these times with this ocular migraine, because the pain, now I know the difference between like a headache and the pain. Because I went so long without getting these ocular migraines. Could those actually have been like TIAs this whole time and just they never caught it because they never did imaging to find what that was?
Yeah. Migraine's tough. I mean, I don't have a straightforward answer for you. We were taught that migraine is stroke mimic and it's not the same. And the problem is there is such a thing as migraine stroke, and I've seen it a few times, and it
Yeah.
is real. It's usually younger women women in their 40s and 50s. The times I've seen it, they smoke, even if it's not a lot. There's good data that, so one, migraine with aura is a risk factor for stroke, which doesn't make a ton of sense, but it is.
Okay.
And especially if you're on an estrogen, some sort of contraceptive with estrogen in it, really increases your risk of stroke. Two, there's such a thing as migraine stroke. So you have a stroke during your migraine. It's very, very rare. I've only seen it 2 or 3 times when I thought it was actually that.
Right.
So it is possible that you just have migraine with aura, and I don't know if you were on birth control at the time or um, you just had a stroke and it was a risk factor for stroke, but not necessarily not necessarily that you've had all these TIAs, that there are migraines and there's some relationship between them, or you have had TIAs. I mean, I think that the TIAs I've seen where it affects vision, it is normally, not always, but it is normally a loss of vision or a darkening or graying of vision,
Yeah.
where migraine is bright, and we call them positive phenomenon. So it's like things are happening, not things are taken away.
So
And
things were happening, but also I lost a lot of my vision. And then as soon as that migraine was done, or whatever it was done, it came back
yeah,
normal until this last time.
and then it's tough, right? What do you do if you have another episode? I mean, I think migraine and stroke it's really tricky, and it is a risk factor for stroke. But I think that if you were my patient, and it's hard to say without more information, but I think the game plan would be, for the first few next times you have a migraine like that was similar to your stroke, we would need to work it up, and then eventually we'd probably be extra aggressive trying to prevent you from having any kind of episode, migraine or otherwise. There's not data that suggests that if you can prevent migraines, you prevent the stroke part, but I do think that. Go ahead.
We
Yeah.
found that when I'm having these, my blood pressure is shooting up very high.
Well, that's a good point. So,
Yeah.
migraine by itself should not cause blood pressure to spike. So that is actually a really good marker. So and if I see someone who I think is slam dunk migraine, but then their blood pressure is 190, I admit them. I mean, just
Okay.
migraine shouldn't necessarily. The thing where it gets tricky is if you're in a lot of pain, your blood pressure would go up. But if you come in with I've got flashes in both eyes and both sides, and my blood pressure is 130, probably not a stroke. If you say I'm having flashes in one side of my vision only, in both eyes, and blood pressure is 190, maybe that's a stroke. So blood pressure is a great marker. That's a good point.
Yeah. And with the blood pressure, it's strange because it's like typically not high. It's been normal. But for some reason we haven't figured out why yet.
Yeah.
It does those spikes, and thankfully with the medication, it's made it fewer and far in between. So it was 6 months before I had, or it's probably actually 8 months before I had the second, or my first episode.
Mhm.
And when I checked it, it was like 137 over 110. And then I took my emergency meds and it went away within like 20-30 minutes. I was back to normal.
Yeah, and that's probably another way. I mean, I think that's a good you've said all the right things in terms of ways to tell the difference. I mean, I think blood pressure, duration, um, those are all good things, but it's tough, and more reason to have a really good relationship with a neurologist who follows you all the time. That's you
That's what I'm
especially.
find.
What's that?
That's what a neurologist, my
Yeah,
neurologist that I currently have. Um, I think they're just so overbooked and overworked. They just see you, ask how your symptoms are. They don't answer any questions. They're
we're
like,
not really
see
set
you
up.
in
Yeah,
6 months.
seeing a neurologist in brick and mortar, seeing a neurologist in a brick and mortar
And
clinic, one, they're not. So the problem is, doctors are not getting paid by the pharma company. They usually do it for a reason. Not saying they're not greedy doctors and selfish doctors and unethical doctors, but unfortunately what happens is the reimbursement shapes what they do. So if you're a doctor in clinic, like a brick and mortar clinic, so in a physical location, most of those doctors are trying to do procedures because they pay more for procedures, and then they try to do new visits, and the follow-up visit after a stroke, and when you're affiliated with a hospital, is actually the lowest paying visit. So a lot of those doctors just don't do it. And it's not the doctors, it's the clinic managers and so, I will
yeah,
say,
that's what I figured. I feel
so
bad.
so so I mean,
Yeah.
that is one thing, and I'm not promoting a product or anything like that, but I think Ralph and I were talking about this a couple days ago, and he was asking, who's a good fit for a service like Centrillo, and it's really people who feel like they still have needs that are unmet, and they don't have a good neurologist. I mean, I think that's where we help out is the bad part of being remote is you're not putting your hands on a patient, you're not able to check everything you want. The good part is you can
Right.
hop on a Zoom anytime. You can still do most of the exam. And what we're finding is that we have really good access. Patients have really good access because they can send us a message or we can get on a Zoom anytime. And so, I think that we're we're kind of piloting patients signing up on the service that are in any state that where we're eligible. Um, we have a certain kind of cap on how many we can see, but anyone based in Virginia we can see, in Tennessee we can see, and then there's a few patients that, because we're working with stroke buddies, we can pick up. So um,
Okay. Okay.
Another good part is the constant monitoring um,
Yeah.
of what they're doing. Um, Nita, you've been very patient. Let's let you go ahead and ask your question, and we'll get to Linda and Tara. Hopefully.
Thank you. Thank you. My question is, I wanted to sign up for your services, but I was concerned because I'm 2 years post-stroke, and what I'm really wanting to work on is my hand dexterity. And I was wondering if there is any way, and if you've ever seen anybody who has recovered their hand dexterity after 2 years. Yeah, but Rolf, you heard your hand come back first. So I don't want to talk about that. It's not fair because I don't want to compare myself with you when you got your hand back first. I have
yeah,
been working on this for 2 bloody years. I'm sick of
yeah.
it.
I think so, Nita, it's tough. I mean, what we would do, say for example, you signed up for our service, so what we would do is we would look and see, is there anything that we can tackle on the risk side or overall health side that might be getting in the way of recovery. Gary asked a question about systemic inflammation, but is there anything that could be a barrier to recovery? We would probably do a little bit more work on the neuroplasticity side than the prevention side, just trying to optimize those things. And then we would make sure that we don't do a ton of tele rehab ourselves. What we do is we think ourselves as we are the service that needs to know the most about the patient's neurological function. So we need to know the most about their mental health, emotional health, their motor function, and their risk factors. And so what we would do is make referrals, and we would vet resources in your area. And I think for someone that is kind of plateaued, we would try to make a push to bolster neuroplasticity, almost recreate a neuroplasticity window, albeit it won't be as strong as when you've at the first few months after the stroke, and then just be aggressive with physical therapy. And actually, we work with a company that's got a couple products, and we wouldn't just send you their stuff. I mean, we would try to find the best product, but there are a couple new products for hand dexterity that are out that are pretty good. And so we could just work with you on what you think would be a good one of those. And our occupational therapist would help with that. So that's the kind of thing we would do for you. But in terms of your question, I think it's got to be sort of two tier, or you got to approach it two ways. How do you optimize the neuroplasticity window, and how do you address any barriers towards your recovery? And then you got to probably do a, a pretty rigorous bout of rehab, because the challenge is 2 years out, it is going to be harder to recover.
One thing, I have a friend who went through traditional therapy and they didn't do much for her hand. And she eventually, on her own, started doing basic functional therapy, using it in every way possible all day long. And at 5 years, she got her hand back. Now, you can't do functional therapy if you're in a complete claw.
No, it's not like a claw.
So, you do what you can. I can tell you, because I did it, that's part of how I got my hand back. And I still do it to this day, because it doesn't cost anything, doesn't hurt. And I figure out that's a way for me to help to keep the gains that I made. So
Nita,
there's a bit of hope.
Where are you based?
In Cincinnati, Ohio.
Okay.
Since I was in Virginia.
There may be someone in the Cleveland Clinic. So there is some interesting work on transcranial magnetic stimulation and sort of reopening the neuroplasticity window. There's someone in Boston that does it, and there's some pretty good data on that. But Cleveland Clinic's phenomenal. So there might be somebody, relatively close to you. I mean, I know you're in Cincinnati, not Cleveland, but there may be somebody that we could try to see if there's a study that where I think that when you're 2 years out or 3 years out, something like that could really kind of tip the scales in terms of reopening the neuroplasticity. So that's something that the transcranial magnetic stimulation's got really good data on that.
Okay, thank you.
We need some more. We need some more trials so the FDA will approve it. Right now, you can. There are a couple of private clinics that have started doing TMS, but generally it's not available except in every city you can get it for depression that doesn't respond to medicine, but you can't get it for stroke. So we need some more data so the FDA will approve it. I did a video on a study on an MUSC, and didn't seem. I'm not a neurologist. I'm not a doctor. It didn't seem very invasive. I talked to the people that were going through the study, so I think we need some more data there. Okay, so who we got next on the queue? I can't see hands right now.
Is there any data on the TMS on what type of stroke it may work towards, like
Ralph,
hemorrhagic stroke versus hemorrhagic versus ischemics? Does it matter?
I don't think it would matter, but I'm not aware of any data looking at that. So I think a lot of the TMS data they look at neurological injury kind of regardless of how you got there.
Gotcha.
Yeah.
So it's worth a shot. There might be hope.
Yeah, there's some pretty promising data. The question is sort of how long does the benefit last, but there's pretty good data that there is a sustained benefit with it, and that it at least is more than just doing rehab by itself. So I think the question is, does it last? I think there's good evidence that it reopens that window, but like Ralph said, I think we need a little bit more data. And the problem with the insurance companies is that even when you get the data, it takes a couple of years before things are affordable and make sense for patients. So unfortunately, That is the way. I was talking to a company. I can't remember the name of it, but they were a stroke rehab company, and they came up with those exoskeletons for people that had really severe strokes and couldn't walk. They had really good data for 8 years. It took 8 years to get insurance to cover it. After they had the data. So unfortunately, the insurance and those devices are so expensive without it. So I think transcranial magnetic stimulations like that. I think the devices that I've seen are pretty expensive. There's going to be some like cheaper devices for consumer use, but I'd be skeptical of those. I think those are not the same thing and that a bit of a scam. So
Okay,
Yeah, I
Linda
guess that's it.
Hughes, and then Tara,
Yeah.
you also have your hand up. Hopefully we can get to these two at least.
real quickly, Ralph, there's a quick question I can answer. Modafinil is helpful, but I can send you some more information about that. Sorry, go ahead.
Oh, okay.
Yeah.
I didn't know. I didn't even see that one in the
Yeah.
chat. Linda?
Tara. Oh,
Yes,
sorry.
I'm here, Ralph. Hi,
Did you?
Dr. Mark. How are you?
Hey, how's it going?
Okay, I had a question about seizures. I
Okay.
had my stroke. It'll be 5 years in December.
Okay.
So shortly after my stroke, I started to have seizures, and they put me on Keppra. And as long as I take my Keppra, my seizures are controlled. So I was wondering, will I ever be able to come off of Keppra and not have seizures, or do I have to be dependent on this medication for the rest of my life?
It's a good question. Um, what we often say is that we can usually work on a trial, like after a certain time period, we can do an EEG and a brainwave test, and then do a trial of coming off of it. I think the issue is if we do an MRI, for example, now, and we still see that there's an old scar or area of injury in the brain, you're technically always at risk for seizures.
Oh,
Um, so anytime there's something structural rather than like a seizure disorder where it's genetic, or sometimes you outgrow those, but a structural problem tends to be a little bit more permanent. I don't think it's unreasonable after a certain period of time to stop, but I don't know. I mean, the problem is if you have a seizure and you're swimming or you're climbing a ladder or you're in a car, it could be catastrophic. So
right.
if you're not, I mean, I know people don't like taking medicines, but if you're controlled on a medicine, it may be best just to stay on it until there's a really clear cost of staying on the medicine, because the cost of having a seizure is pretty massive.
Okay, I get it.
Okay, Tara, you got a question?
Thank you.
Yeah, it's a twofold one because I don't know if you guys can see the chat. Mine information goes along with hers, and I'll just read her thing in chat. The Susan Kenny or Kennelly, whatever her name is my neurologist said I didn't really need him. Also, when I complained about balance issues, he said, "Yeah, you are clumsy." Well, I'm 2.5 years post-stroke, and I can walk like within my house, fine. Even sometimes I can make it to the end of the block there to get my mail. But I feel more confident with my walker, but I do use my cane quite often. I just want to be able to walk like normal. And I don't know if it's a brain thing, a psychological thing that I fear I'm going to tip over, because I would love to go walk parks and get my long distance walking. My
Yeah.
short distance is great. And then I'll tell you one other thing, and then I'll let you answer me. I was trying to help Susan out too, since she had that question there, because my neurologist, he didn't call me clumsy, but he kind of just said what you said at the beginning of the presentation. They see you once and then they just let you go.
Mhm.
And I told him way back then that I had balance concerns. Will I ever get them back, or am I going to be balanced, whatever? And I don't know if it's psychological, like I'm just freaked out, and if I fall, because I do live by myself, so I don't have someone to grab
we
my arm or
we
walk
s-
next to me.
we
And
see that.
one more quick
Sorry,
thing,
Tara, go ahead.
then
Yeah,
you
my
can go
apologies.
ahead with it.
Yeah.
There was a guy that came to my stroke support group. He was from, I thought it was called InTandem, and their med rhythms. It's just a bona fide cell phone with an app that does like your metaphysics or your tones, and they claim with their data that that device is good for stroke patients like me to do long distance walking. And I wondered if you worked with them or heard of them. The one gentleman was from Columbus, Ohio, the sales guy, but the engineer was from Maine. So I'll let you answer all that now. Thanks, sir.
Ralph actually introduced me to the CEO for MedRhythm, so I do, and Ralph can tell you more about that. But he seems like a good guy. He's got a good background, and they have some good data. So I overall believe in MedRhythms from that perspective, but I don't. Ralph can tell you more about that and share information. I haven't used it for my patients, so I can't. I'm speaking more to generally what I know about that individual and their company is positive, but I haven't tested my patients, so I wouldn't.
Okay.
I'd have to sort of educate myself more
What are hopes
before.
for me balancing and walking now? That part of it.
Yeah, so I see this a lot, and it is a big thing that we tackle. It's one of the most common, I'd say, rehab related issues, and I think there's a small element, it's sort of like that phantom limb, where it's a sort of maladaptive learning. I do think there is a kind of a confidence in security standpoint. I also think that there's a real deficit that needs to be addressed, and you know, I would we try to one we find that if you even if you're a couple years out, usually if you kind of make another push for physical and occupational therapy with a team that's keeping track of it and giving supplemental exercises, it can be helpful. Um, the other thing is like, what are some things that make it worse? So a big problem with once you have impaired proprioception or coordination is um, there are things that you can use to compensate for it, like visual cues often help. Like, I don't know, finger to nose. If you watch your hand do it, then versus if you're doing it without, it can be more challenging. So um, what we'd want to do is make sure there's no neuropathy, there's no orthostatic hypotension, there's nothing else that's contributing to that, and then it will be part. How do we aggressively see if we can make improvements with your balance, and then also how can we use vision and other cues to compensate. But I do think balance is an area where there can be good improvement, but there tends to be more than one issue affecting it. And I think there is a small psychological component, but certainly I think it's the minority of the factors contributing and not the majority. So I would never say, I think it's your anxiety. I don't think that's true, but I do think that there's sort of this learned fear of walking. But I mean, I don't dismiss the need for an aggressive kind of, multifaceted plan just because there might be that underlying fear.
So you think with my primary physician, I see her in a couple of weeks. Do you think I should just ask her for therapy again to help my balance skills?
Why not?
Yeah, I think it's always good. I mean, that's I think it's always good to ask. Ideally you have a neurologist that's the problem with the primary care doctors, they're going to make a referral and then they're going to just leave it, they're
Yeah,
going to
they
what,
do. Yep.
and the
I do
problem
have a rehab doctor. Should I ask him? Would it matter?
that would be better. Yeah, that'd be
Do
better.
him? Okay.
Yeah,
I don't see him till April, but thank you,
yeah,
sir.
yeah.
Okay, I'll make this as brief as possible. I tested the InStride product for MedRhythms twice, where they analyzed my data. Also, Winnie's still here. She did it also. Found it kind of helpful. I don't want to contradict the neurologist, but I've got, and this is totally anecdotal, but I've helped several people. Well, first of all, I went to the mall to get over my fear of being around people. I think there is some portion of this that's fear or psychological. Also, I've helped a couple of people go from walkers to quad canes to no cane. And I've said to a couple of them, well, I've seen you do this in other places. You got this, trying to build them up as a coach. And I say, it's 90% fear. And I had one of them turn to me and say, try 100%. So I think there is some psychological thing. I literally went to the mall at 10 o'clock and because I thought everybody was going to knock me over. My walking wasn't as good at the mall as it was at home or in my driveway or neighborhood. So that's my 2 cents. One thing I think that the InStride product did was it plays music and it has a metronome in the background. When you get off the metronome gets louder. That's real helpful because it keeps you. Dr. McDonald will tell you this. Actually, it seems counterintuitive, but the faster you walk safely, the less likely you are to fall. So it helps you keep up a steady pace. I like the metronome coming up. I love the Motown tunes. You can pick whatever. And I found that the music and the metronome kept me focused on my walking and prevented me from overthinking. I'm a real overthinker. And if you overthink when you're walking, I think it works against it. It did for me. So that's my 10 cents worth.
I have something to add to what Ralph was saying. So in Scotland, it's super cold here. So in my experience, when I go out walking, especially in these seasons, I try to focus on keeping my arm straight because it tenses up and it pins to my chest. But the more I focus about the arm, the more I lose complete control of the ankle. And then over 50 feet, the ankle is destroyed.
I call that, there's a neurological term for it, but I call it running out of brain. When I walk to the table every night, I practice walking with two things in my hands, and I have an intentional tremor, and so my left hand, the plate, I'll carry the plate in my left hand back to that functional therapy thing, Nita, and I got a choice. I can stop the plate and my walking falls apart, or my walking can be perfect and the plate shakes. I can't seem to do both. I call it running out of brain, for lack of a better term. So, okay.
Gary, real quickly, I just wanted to ask you, since you helped set this up, I see some questions going through. Can we, for people that weren't able to get their questions asked, can we just make sure we grab them from the chat before the meeting ends? And I'm happy to answer those. And then Gary, I think Gary's going to follow up with information also for anyone that wants to sign up. But yeah, I'll feel free to send a question. Even if you think of a question after this, feel free to send it to Gary or Ralph, and I'll try to help out with that.
Well, also I'll put your information and the link to your patient portal in the description underneath this video. And
okay.
I thought another thing we could do would be to send the post about the service out to all the people that registered, so they'll just flat out have it.
Okay, that sounds like a plan, Ralph. Yeah.
But we'll also get you the questions if they're in. When I'm recording, so I get the chat and I'll look through the chat and see which ones we didn't answer and send them on.
Okay, great.
Anybody else? Speaks kind of like a wedding. Speak now or forever hold your peace.
There you go.
All right. Well, William, is it? Yeah, you got a quick question?
Yeah. I had a stroke 21 years ago, and I had another one 3 months ago.
Ooh.
And I had it when I was in the shower. I fell and broke my neck. So I was in the hospital for like 3 months.
Ooh.
And the neuropathy in my arms is terrible. Down through my fingers, my my ring finger and my pinky finger.
Mm-hmm.
The neuropathy are unbelievable. I thought it was from a broken back, but I hear others talking about stroke. Is it
in both hands?
Yes.
And it moves down your arm?
It's not as bad. It's worse in the left hand. It's only the pinky in the right hand.
And it moves, the pain kind of moves down your arm. It feels that way. Yeah, it's probably from your neck.
Yeah.
I mean, on some level, the strategies you deal with it are starting to become the same. It's still in the neuropathic pain class, but radiating pain in both arms, even if one's more severe than others, after a neck injury, probably is going to be related to impingement of the nerve or
that's what I was kind of figuring.
Or the spinal cord.
Well, that's more helpful. Okay, thank you.
As a stroke survivor, I can't tell you, I'm not the neurologist again, but as a stroke survivor, I find that when you have something affecting your whole body, it seems to be accentuated on the stroke side. So that may be why you're feeling a little bit more of it on the stroke side.
Yeah. Okay.
For what that's worth. It's not a scientific answer, but it's what I've observed in helping other people.
It's helpful learning from other people like this. It really is, because I was in the dark about a lot of stuff.
You've had it rough.
Yeah.
Yeah, sorry that that's terrible, William. I'm sorry.
Really ended up not only that, while I was in there, they repaired my heart. so they took the opportunity to repair my heart while I had a broken neck, and I broke my neck, and I broke my lumbar, my L1. I shattered that one.
Okay.
And then I went into the hospital and they operated on the heart because I had a murmur. So I had a stroke beforehand. I was messed up. The last 3 months have been a total.
Gosh.
Hopefully your neuropathy will go away eventually.
I hope so.
It sometimes does. I have a friend who broke his neck and he still has some spasticity, but a lot of his neuropathy went away. I can't say that'll happen to you, and happy healing. Hope.
Well,
maybe they have you all fixed up now.
Yeah, maybe. I got a lot repaired.
All right. Well, we need to end this. I've got it on our weekly Thursday meetings at 2:00, and we've exhausted. Dr. McDonald, thank you for staying and answering all of them, and your willingness to answer anything that didn't get answered, and for all the time. I think this was real valuable to anybody and everybody who attended, and anybody and everybody who can watch it or replay on YouTube. So thank you.
Thank you very much.
Yeah, it's my pleasure. I'm happy to do this again too, Ralph. So we'll find time.
You've been so busy the last year or two. You and I talked about doing this a couple times a year, and I think it would be real beneficial to the stroke community. But I don't press people, and you've been ridiculously busy the last year or so. So anyway, thank you, and thanks to everybody for coming. And if you have any follow-up stuff, you can we'll send you an email. The contact information will be underneath, and you can always go through either Gary or I as well. So we've got 3 channels if you need information.
All right. Thanks, everybody.
Thank you.
Thank you, Dr. McDonald.
Thank you. Take care.